Welcome everybody to this PEDro Journal Club, and we're joined by some discussants, so I'll get them to work around the group and introduce themselves. So Lisa, would you like to start?
Hello everyone, my name is Lisa Spencer. I'm a physiotherapist at Royal Prince Alfred Hospital and I work in pulmonary and cardiac rehab, and I'm very interested in the area of tele-rehab.
Hi, I'm Sally Witten. I am a physiotherapist with the Northern Sydney Local Health District Pulmonary and Heart Failure Rehabilitation Programs, and similar to Lisa, very interested in rehabilitation options, including tele-rehabilitation and the use of technology to support patients doing exercise training and physical activity coaching at home.
Hi everyone, my name is Josh Hain. I actually work with Sally at the Chronic Disease Community Rehab Service.
And I'm Mark Elkins. I'm one of the co-directors of PEDro. And I suppose the review covers three main study questions, so I suggest that we work through those one at a time. And an interesting approach in this review is that it doesn't focus on the dichotomy between statistical significance and lack of significance, or the treatment does work or it doesn't work. Instead, it looks at estimating the size of the treatment effect and what uncertainty there is around that estimate, which is reflected in the confidence intervals. So we'll be discussing that a bit on the way through. If people are viewing this journal club and then not that familiar with that idea, there are some great, easily understood papers by Camper and by Herbert, and I'll add those to the reference list that goes with this recorded journal club. Before we delve into the first study question, did people have comments about the methods of the review?
It's a well-written, systematic review. They've set out their aims very clearly, three main aims, and they have addressed these aims throughout their review. They've included all papers that use advanced technology, so they've eliminated any phone-based telehealth and focused on advanced technology, and included all the inclusion-exclusion criteria. It's all very well set out.
It's a nicely written review, Mark. As Lisa said, very nicely set out. Included papers that weren't in English, which I think is really important, often not done, and also very clearly talked about when reviewers couldn't agree, how that was dealt with. So I think the methods were really clear and laid out well for the reader.
And yep, I thought they included a really nice range of evidence. They made a really good attempt to contact the authors of the abstracts when it was just the abstract that was available and they needed further information. They just made a really good attempt to capture the most up-to-date evidence and really recently published studies.
Okay, let's then move to the first study question, which basically boils down to how effective is home exercise therapy with this technology support. Lisa, what did you think about the findings for the effect on exercise capacity?
Yes, so I think they chose good outcomes that have been very well validated in exercise programs in patients with COPD, and that is the 6-minute walk distance, incremental and endurance shuttle walk distance. So 4 main studies showed an improvement in 6-minute walk distance of 15 metres with a confidence interval between 5 and 24. And those papers were Tsai, Demeyer, Nguyen and Tabak. Now, if we just look at their forest plots and you look at the first 3 papers, Tsai, Nguyen and Tabak, the total estimated average did not cross, was sitting on the line of no effect. However, when you added the largest study by Demeyer, which was a large study, it pushed the total estimated average to the positive side, showing that there was an effect on the 6-minute walk distance. Admittedly, the effect is smaller than we would normally see in pulmonary rehab, so it was 15 metres. However, 15 metres could be a worthwhile difference for a patient who's unable to walk to their letterbox. So we have to put that in perspective. It's important to add, I think, that in these programs, there is no supervised walking. So we wouldn't really expect to see as large an MID as we would in, for example, a face-to-face pulmonary rehab program. So all the intervention was advice, goal setting, motivational interviewing, and apps, and so on, to try and encourage the patient to increase their physical activity. The incremental shuttle and the endurance shuttle walk test had different results. So there was no real mean improvement in the incremental shuttle walk distance, but there was in the endurance shuttle walk distance, and they had a good improvement of 340 seconds. So this was a very good result, and it's something that we would often see in a supervised pulmonary rehab program. So that was quite positive, but interesting that it wasn't reflected in improvements in the 6-minute walk distance. So each of those studies had slightly different interventions, obviously. 3 of them used smartphones and motivation and goal setting, and the study by Sai involved home visit, a delivery of a bicycle, computer and SATS monitoring, so much more like a traditional pulmonary rehab program, but via tele-rehab.
Yeah, so a bit of a mixed bag there. It's, you know, some really nice results on some exercise tests, a bit underwhelming on others. What do people think about their quality of life results?
Yeah, so thinking about the quality of life, similar to the exercise capacity measures, different measures were used. And they were appropriate measures in the fact that they were disease-specific measures, such as the St. George Respiratory Questionnaire and the Chronic Respiratory Disease Questionnaire. And they also used the Clinical COPD Questionnaire. Because all of those questionnaires actually end up with different results, sometimes a lower score can indicate a better result, and sometimes other ones the opposite. What they did is in the meta-analysis, where they included 4 of those studies, they actually standardized those results and reported it as a standardized mean difference, so that they standardized all the quality of life scales, which was good. Looking at the forest plot in figure 5, A for quality of life, where they've included similar studies to what Lisa discussed with the exercise capacity measures. Again, the quality of life standardized mean difference was generally considered quite small, around that 0.2 level, and the confidence interval did show the intervention may improve quality of life, or it may make no difference at all because it did meet that 0 line on the confidence interval. Similar to Lisa's comments about the studies, they are mixed in terms of what the interventions were and how much feedback was given and how much educational support. So although we know patients can improve quality of life from just exercise training, often additional benefit comes when extra interventions are added, such as education, self-management support, around exacerbation management and those types of things. Certainly some of the studies that were included also looked more at exercise training, such as Sai's study with the telerehabilitation model versus the Moy study, which was more around physical activity training. So both of those have a slightly different slant in terms of what you may expect with quality of life results.
Okay, and what about the effects on dyspnea? What did people think?
I thought it was really interesting when you look at the 2 studies that were analysed in the review. They didn't, in and of themselves, they didn't find a statistically significant effect on the dyspnea subdomain of the chronic respiratory questionnaire. But when you pulled that analysis, that was enough to get that confidence interval favouring the intervention, so favouring the advanced technology, telehealth technology. And we could be reasonably certain that that treatment effect was on a minimally clinically important difference, so a positive for our patients.
Yeah, so that figure 7A is a really beautiful example of where you have a couple of underpowered studies, and if you, not underpowered, but a couple that don't have sufficient power to reach statistical significance, and if you were to just think of them in terms of statistical significance or not, then you'd say, oh, the treatment doesn't work. And yet by pooling them, we can see a more precise estimate, and then we do start to see that effect. So that's a nice finding. I suppose among the rest of the outcome measures on that first study question, one of the interesting results is the physical activity, the step count. So the best estimate is it's 900 odd steps improvement per day, which I think we'd agree would be worthwhile for a lot of people. The lower end of that confidence interval is around 425 steps, so not quite as good, but even then, it's still a definite benefit. You know, the confidence intervals well excluded 0. So I guess it's a bit of a mixed bag overall for that first study question. We'd some clear benefits have been shown, but there's a lot of outcome measures where the results are unclear. And I suppose that means a couple of things. One is that there's an opportunity for further research to get more data so we can narrow those confidence intervals further and come up with a more precise estimate of, you know, is it worth doing this home-based exercise with telehealth support versus not doing it, and get a clearer picture on other outcomes. But also, we may start to think about those in terms of, was that benefit as good as what you'd get with centre-based? And can be a bit misleading to compare these results to systematic reviews of the average effects you get with, say, centre-based pulmonary rehab, because they're not randomised head-to-head comparisons, but that's what we do get in the second study question for this review. So rather than dwelling on that, we should move to the second study question. So this is a home-based exercise with telehealth support versus in or outpatient-based or centre-based rehab or exercise programs, which could include, for example, pulmonary rehab. So, Sally, what did you think about the effects on exercise capacity?
Yes, Mark. Well, it was interesting looking at the results in terms of exercise capacity. So when people are looking at the paper, we're looking at figure 3 and forest plot B. So there were 2 studies that they mainly looked at here, being the Hansen study, which was mainly looking at telerehabilitation. And that study was very well set up in terms of the frequency of exercise training, the dose, the intensity. And then there was also the Born study, which is part of the UK-based MyCOPD platform, where patients are exercising at home following videos from an app-based program. One of the interesting things about that Born study, and this was the study obviously that the confidence interval was more on the side of favouring the technology-based intervention, is when they actually compared centre-based rehabilitation, they actually compared the same type of exercise training in the centre to what they did at home. And when we compare that type of training to what we do in Australian-based pulmonary rehab programs, it's very different. They really didn't have a big endurance component, and the only difference between the 2 settings was the medium in which the patients were exercising. So it's not surprising that there wasn't much difference there. But as I say, the Hansen study, which again, slightly on the other side, it's much tighter confidence interval and favouring the outpatient setting for training, that was actually really good setup telerehabilitation. So looking at the pooled effect, it's showing us that really you might not choose centre-based over technology-assisted rehabilitation. But as we know, there is a huge amount of evidence that says that centre-based rehabilitation is the optimum way to provide care. So we certainly wouldn't be changing our practice based on just these 2 studies in this meta-analysis.
I was just going to say I totally agree with Sally, because I think there's a tendency when new literature comes out and everybody goes, oh, great, the ATT, ET was fantastic, it was as good as pulmonary rehab. There's a tendency to throw the baby out with the bathwater without actually looking closely at the results like Sally just did. And you're right, Sally, those studies were very different. That Born study was just 10 exercises that they followed and they did progress them. But the other study was more like a true pulmonary rehab study. So I think you're right, we have to interpret with care always.
And what about the dyspnea results?
Yes, they compared the dyspnea using the Chronic Respiratory Disease Questionnaire and the Modified Medical Research Council score. And these tools are both appropriate. They've been validated in pulmonary rehab programs. And the 2 studies that were analysed for that found there were similar effects for both interventions, again, small. And when you look at the forest plot, the average of the 2 studies shows that there was no real difference between both interventions, supporting the fact that the ATT-ET intervention is effective from these studies, is as effective as pulmonary rehab in reducing dyspnea.
So what are people's thoughts overall on this comparison?
I think definitely more work is needed. And as we know, tele-rehab is just emerging and there are so many different types of rehab. But I think it gives us some confidence in that if patients are unable to attend face-to-face pulmonary rehab for whatever reason, and we all have experience in that, then we can offer them something that may improve their dyspnea and quality of life.
I think one of the important things when we're undertaking these remote exercise programs is thinking about adverse events and the safety around these programs, and certainly both in this comparison and throughout. Although adverse events have been reported, there haven't been any serious adverse events, so it's more around musculoskeletal pain and similar issues. And although the previous comparison we discussed was against control, so there were slightly more adverse events in that, but obviously those control groups weren't doing proper exercise training or activity. Whereas in this study, when they were comparing a centre-based program versus a home-based program with the support, there wasn't really a big difference in adverse events. So I think that's important when you're thinking about implementing these strategies. And then obviously cost effectiveness is really important with these types of interventions and the time that it takes to set patients up. I think most physios in pulmonary rehab across Australia and the globe have kind of worked very hard to look at home-based models supported through tele-rehab or telehealth, but it's often the time that goes into setting those up in new settings and might not have equipment. And also access for the patients to those types of technologies can be a limitation as well.
Yeah, I think that's a really good point, Sally. So one of the strengths of the advanced technology tele-rehab is for the patients who can't make it to centre-based. But what the authors of the study also say is that the cost or the burden to the patient should be explored as well. And if they are in a position where they can get those comprehensive interventions at home, then that's something that we should explore.
Okay, so if we haven't really been convinced by the evidence in this second study question that, we could possibly say that home-based exercise, even with telehealth support, is necessarily equivalent to centre-based programs. We have so much evidence about clear benefits from centre-based programs. We've got some rough equivalents here, but so much uncertain, enough uncertainty to make us not be able to say, oh, let's ditch centre-based programs, by any means. And as Josh points out, we've got some people who perhaps can't make it to a centre-based program. Then I think if we are going to offer those people home-based programs, it'd be good to know, is it worth incorporating these advanced technologies into that? And that's really the third question of this review. So these are comparisons of both groups got home-based exercise therapy, but one group got the addition of the advanced telehealth support. So what did people think about the results here?
Only one study, when we look at exercise capacity or improvements in exercise capacity, one study looked at the endurance shuttle walk test. So that study had about 48 people that it was looking. And when we look at the study design, there was daily monitoring, daily feedback, instructions, progressions, those types of things. And they found quite a meaningful improvement in the endurance shuttle walk test with the advanced technology compared to the non-advanced technology exercise therapy group. Whereas we look at the data for the pooled data for the 6-minute walk test, they didn't find as clear-cut results there. They weren't able to show, statistically significant result there. But what the authors also note is they didn't actually they would have liked to do some subgroup analysis. So the actual advanced technology that they looked at did vary among the three studies, the 3 studies for the 6-minute walk test and the 1 study for the endurance shuttle. And so they weren't able to kind of make any solid conclusions on the type of technology, the type of advanced technology that should be used there.
One of the things I really liked is the Lou study from 2008, I really liked the way they did their intervention with the cell phone to try and pace the patients for walking, because that's one of the things we often think, that if the patients are supervised in real time, either in the centre or through tele-rehab, that they'll maintain the pace and the intensity of their exercise training. Whereas if they're unsupervised, they actually go a bit slower because they might be feeling more breathless or a little bit more anxious exercising on their own. Whereas this actual technology, based on their initial exercise capacity, they set the tempo of the music for the patient to walk along to. I think that was a really neat way to set that up. And I think that did reflect in that study having improved exercise capacity results. So again, it's the way that you use the technology and really try and specify for the patient how they can train and how they can improve.
And again, I suppose choice is important too. If we're trying to apply these sorts of technologies to real patients, it's about what is appealing to them. What are they actually going to use? Because ultimately, that's what we want, don't we? We want people to actually use it and not just say that's too complicated or we're not going to use that at all.
And certainly with all of this review, they've not really gone into that in terms of kind of using those technologies over time. Certainly the evidence is suggesting, particularly with app-based technologies, that people are often quite engaged for those first few weeks.
That's right.
And then they drop off their engagement. So it doesn't matter how good that program is, if they're then not going to get engaged with it and maintain their motivation to be part of it, as they might do if they know they're coming to an appointment 2 or 3 times a week, they just won't do it. So that's
it's like gym membership. You don't go, it doesn't work.
So we charge for pulmonary rehab, Lisa.
That's right.
So any other comments about the results in that third study question?
Yeah, so if we then kind of look at the quality of life around those kind of home-based interventions, again, similar to all the results we've been looking at, when they look at those kind of mean estimates or best guesses, they're slightly above what we would think is the worthwhile effect. But there's, although the confidence intervals are quite small, it's slightly favouring the ATT and the technology, that you'd actually get improved quality of life when you add that onto a home-based program. But the pool difference does slightly cross the 0 on the confidence interval as well. But again, I think the Newen study actually had a really nice web-based tool with lots of kind of support within that program, and so that may have had a knock-on effect, that was having more effect on quality of life and how the patients were feeling and self-managing, versus the Lou one, which was more around kind of the exercise training and targeted intensity. So with those results, probably makes it slightly better to have those technologies involved in home-based training, but again, no definite certainty around that.
A Cochrane review came out about a month after this paper, and they're on not exactly the same topic. There are a few distinctions in the methods. Did people have comments about the comparing the 2 systematic reviews?
Yes, so it was very, very timely, and again shows the interest in this area, doesn't it, with 2 reviews coming out. So Narelle Cox, who we know is an Australian author, she looked at 15 studies, so it was a large number, 1,904, and 5 different models of tele-rehab. So she included she included telephone, mobile apps, again, that's similar, video conferencing in a virtual group or through use of websites. So she basically included any sort of tele-rehab at all. The differences to the review by Bonvi were, she included all respiratory conditions. However, 99% were still patients with COPD. And as I just said, all modes of tele-rehab. And the similarities, there was little or no difference between tele-rehab and face-to-face pulmonary rehab in terms of 6-minute walk distance. I think, so that was very, very similar results. And there was little or no difference for health-related quality of life as well. And that was measured by St. George Respiratory Questionnaire, Chronic Respiratory Disease Questionnaire. So that was very similar to Bonvi's results as well. And I suppose the other interesting things that she did report was that it was a very good completion rate, so 93% completion rate, as opposed to, she reported 70%, I'd say more like 60% for pulmonary rehab. But so that was really very promising. If people actually complete a program, they're more likely to actually achieve results. So that was very promising. And she reported no adverse events, so it wasn't clear exactly what she counted, but she excluded musculoskeletal issues and just included, major issues. When she compared her results to no rehab, she saw an increase in 6-minute walk distance of 22 metres. So that was more than Bonvi got of 15 metres. However, the confidence interval crossed the line of no effect.
I think that difference between the Bonavie and the Cox review is she was looking at kind of the more kind of proper rehabilitation interventions, rather than the Bonavie included those physical activity ones. And just because you improve someone's physical activity levels doesn't mean you'll then improve their exercise capacity in those types of tests. Yeah, I think it's really timely that they both come out together. And if you're interested in this area and you read both of them, then there's a lot of good information there. Again, as clinicians moving forwards, and what do we do with this evidence? You always have to remember, as Lisa said, who did they include and who did they exclude? Because as we all know, when we're recruiting to research trials in our normal pulmonary rehab programs, often those patients that are very, very complex, are a little bit unstable, maybe don't speak English, certainly in our kind of metropolitan programs, they may not be included in these types of research studies. So when we're thinking of our overall results and changing clinical practice, that needs to be at the top of our minds.
Any other comments?
I think the study or the review that we looked at, the types of the telehealth technology and the duration of the interventions provided really varied widely amongst the studies that they looked at. So we can't really draw any conclusions from the available evidence, at least the ones that they looked at, for our practice. So as both Sally and Lisa have said, for those, we want to include, basically catch the widest net of patients that we can for pulmonary rehab, because we know if they do it and if they complete it, they'll get a benefit from it. But in terms of looking at or kind of having a more concrete grasp of the benefits of this advanced technology, the evidence isn't quite there yet.
But great to say that it could work. It can have some benefits, and if a patient is therefore able to access and will complete, and we can give them that choice confidently that it's safe, then it's a good avenue to take, as long as resources are there to provide it. Often I think we're well resourced in metropolitan programs, but in more rural and remote settings, it's often the nurse or the physio popping down from the ward to run the pulmonary rehab programs, and then they might not have the time or the equipment to then set up these extra programs on top of that when they're also working on the wards. So I think different programs will have different uptakes of technologies over time, but certainly e-health and m-health is where we're all headed. And we have to be open to looking at different options.
No, I agree. I think it was very promising, and it may offer an option for people who are unable to access pulmonary rehab for whatever reason, and we know there are lots of reasons. I think the thing I drew out, that obviously there may not be enough supervised walking in these programs, so there may be a better way than just coaching and motivating, that we might have to set walking goals. And perhaps longer pulmonary rehab, tele-rehab programs may be needed to achieve results, but ultimately pulmonary rehab remains the gold standard.
All right, well, thanks everyone for all your comments. It was really wonderful to get your insights, particularly into, the intricacies of individual papers, and it's a good lesson to always keep that in mind when you're looking at systematic reviews. It's not just to blatantly look at the pooled results without thinking about, how individual studies were done and what they're contributing. So that was really nice to have all of your expertises combined. to review this paper. So thank you, and I look forward to seeing everyone at the next Journal Club.